Well, greetings everyone and welcome to the EKG case for the week of September 23rd, 2013. My name's Mattu at the University of Maryland School of Medicine. Before we get started this week, I just want to send a shout out to friends up at the University of Western Ontario in London, Ontario. I had a chance to visit them very recently, and it was just a really, really wonderful visit. Everybody up there was just so hospitable. My main hosts were Doctors Laura Foxcroft and Dave Willett. And Dave, I hope I'm getting your name properly pronounced. There's a lot of letters in your name that appear to be silent, at least according to the online program that I punched your last name into, and it told me how to pronounce your name. Anyway, while I was up there, I didn't specifically ask Dave how to pronounce his last name. I just said Dave. Anyway, Dave and Laura, thank you so much for your hospitality, and all your colleagues, residents, and faculty. Just a wonderful, wonderful group of people. But of course, they're Canadian, so what else would you expect? Anyway, this week's case is sent to us by a resident by the name of Dr. Joshua Batt, who is a resident in emergency medicine at the Arrowhead Regional Medical Center out in California. And dare I say, Joshua is an up-and-coming EKG nerd himself. Hopefully he won't mind me saying that. I was very impressed with the pickup that he made in this particular case, and I think you'll agree with me as we go through that. He is going to be earning his NE degree very soon. NE, of course, stands for Nerdus Electrocardiogrammus, for those of you that never studied Latin. So here's the case that he sent. It's a 67-year-old man who presented with a history of end-stage renal disease. He had fevers, bacteremia. They were a bit worried about early sepsis. And there was some question about whether this patient had a history of chronic AFib or not. I think it was in the history, but he wasn't chronically on anticoagulants, so it wasn't a definite thing, but it got thrown in there somehow. The potassium was normal, so I just want to get that right off the table. Of course, anyone with experience dealing with renal failure patients knows that whenever you see somebody with renal failure or end-stage renal disease, the first, second, and third diagnoses to think about are hyperkalemia. But let's just get rid of that right up front. The potassium level was normal. Okay, so that's not a hyper-K case that we're dealing with. Well, here's the 12-lead EKG that he got on this particular patient. There's a lot of artifact, and that certainly is a fact of life. We oftentimes have to deal with artifact in our patients. There's a few things that you might see that we're not going to address in this particular case. There's a right bundle branch block pattern. There's a lot of artifact, and maybe there's a little ST segment elevation that the computer is making a fuss about, but it turned out not to be an inferior MI, probably just artifact. We're not going to talk about that. We're also not going to talk about the right bundle. What I really want to focus on for the purpose of this case is really just the rhythm. All right, so we're going to be focusing on the rhythm, and that's what we're going to discuss. Excuse me. The rhythm here is kind of tough, though, because there's a lot of artifact, and it's really difficult to see whether there's any clear-cut P waves that map out. The machine is calling this atrial fibrillation. Take a minute, hit the pause button, and think about whether this is AFib. Try to figure out yourself what the rhythm here is. All right, so hit the pause button. We'll be back in a moment. And we're back. And hopefully you didn't cheat and you did actually try to figure this out. Anyway, one of the rules that we've discussed before is that when you've got atrial fibrillation, you must have a rhythm which is irregularly irregular. Unless somebody is DIG toxic or something like that, AFib produces an irregularly irregular rhythm. And if you look carefully at this rhythm, you'll notice that it is not irregularly irregular. Instead, there are clumps or groups of four. Marriott used to call this clumped beats. Other authors call this grouped beats, whatever you want to call it. There's clumps or groups of four all the way across this. So that would suggest that this is not irregularly irregular. And the other interesting thing, just if you're doubting that, if you look at the distance between the clumps, so say this distance, that distance, that distance, those are all identical. I'll get some calipers here, okay? And I'm going to use these arrows as calipers. I'm going to take this. So this is the distance between these two clumps. I'm going to move that arrow without changing the size of that arrow. I'm going to move it over here to see whether that is the same size, and sure enough, it is. the distance between the clumps, we'll move it over one more time, the distance between each of the clumps of 4 beats is exactly the same. So that's the first clue, or the first, I guess, guarantee that this is not an irregular rhythm. Furthermore, what I did was I took arrows and I just point the arrows at each of the 4 beats in each clump. So there's a clump, there's a clump, there's a clump. Let me move this over here so you can see the end of that. All right, so there's your clumps, and I'm just going to take these arrows and I'm going to move them over here because I want to find out whether those arrows will line up then with these QRS complexes exactly also. So you move that over, and sure enough, it does. Move it over, it lines up once again. In fact, if you move it all the way over here, it lines up there as well. So these are right bundle branch block conducted beats. This beat looks like it was conducted without a right bundle, and that's why the morphology is a little bit different. But it doesn't matter because it still lines up with the arrow up there. So maybe I'm beating a dead horse here by showing all these arrows and everything, but the key point here is that this cannot be atrial fibrillation because this is not irregularly irregular, all right? So if it's not irregularly irregular, it's not AFib. When you see regularly irregular rhythms, there's 2 main considerations. Mobitz 1 or Mobitz 2 very typically does this and often gets misdiagnosed as AFib. Sometimes if the final beat in each group is a PAC, you may also end up with a rhythm that is regularly irregular. In other words, if the final beat in each group is a PAC, premature atrial complex in there, that can produce a pause before it starts up again. But, I don't really see any PACs right before the final beat in each group. So it's not obviously PACs. So my money is starting to look at, to fall on Mobitz. Mobitz 1 or Mobitz 2 in all likelihood is what's going on. Key point, once again, it's not AFib. The computer, once again, as usual, is wrong. Don't rely on the computer. The computer calls everything AFib. In fact, there's studies suggesting something that we've talked about before. AFib is the most commonly overdiagnosed, misdiagnosed tachydysrhythmia, because anytime there's any irregularity, people just call it AFib. Your computer does that also. Be suspicious. Look for regular versus irregularity. All right? So, now Joshua was able to get a better baseline EKG finally, and after some attempts, he finally got a better 12 lead, and here it is. So, a lot of the artifacts gone. You notice, however, there is still some irregularity. There's some aberrantly connected beats out here. Those are probably PVCs, or I'm guessing that they're PVCs. Let's ignore those. Again, I don't want to talk about that. What I want to talk about is the intrinsic rhythm right there. It's irregular, and you'll notice now instead of groups of 4, there's actually groups of 2. All right. So again, we're still thinking about the possibility of Mobitz going on here. So what we're going to do, we're going to cut this part of the EKG off. We're going to get rid of this lead 2 rhythm strip. Once again, lead 2 fails. Okay, this is another takeaway point. Lead V1, we've mentioned before, lead V1 is oftentimes your money lead. And if you look at this entire 12-lead EKG, V1 is the only lead, I think, that gives you good P waves to study. So we're going to take lead V1 and we're just going to blow it up or cut out all the other parts of the 12-lead EKG, blow up lead V1, and this is what we got. Now, we're going to look carefully for P waves on this thing. Well, it looks like that's a P wave right there, and I think that might be another P wave there. All right, if we map that out, where do our calipers take us? It take us right there. And then the calipers take us to that beat, and then there's a beat there, and beat there, and there, and there. And actually, this maps out completely regularly. So there is definite atrial activity that is very regular that maps right out along this 12-lead EKG. Now, there's obviously more P waves than there are QRS complexes. And so that also supports the potential diagnosis of Mobitz. Question, is this Mobitz 1 or is this Mobitz 2 then? How do you know the difference between Mobitz 1 or Mobitz 2? You need to look at the PR interval. So let's take a look at the PR interval. There's a P wave right there, and there's a PR, there's a P wave, and a longer PR, P wave not conducted. And then it starts again. P wave with a reasonable PR, P wave with a longer PR, P wave not conducted, and so on. This is a Mobitz 1. And you know what? If you didn't take a good close look at V1, if you didn't take your calipers and march it all the way across that 12-lead EKG, you might be misled into thinking that, well, you might not realize that that's a P wave right there, and you might not realize that that's a P wave, and that's a P wave, and so on. So sometimes using these calipers can be very, very helpful at telling you where some of the hidden P waves are. So again, this is a Mobitz 1. There's 3 P waves for every 2 QRS complexes. So 1, 2, 3 P waves for 1, 2 QRS complexes. So we end up calling this Mobitz 1 with 3 to 2 conduction. Key point again, this is not atrial fibrillation. And that's a big, big deal because this patient actually was initially diagnosed with atrial fibrillation, even by cardiology. And Joshua was probably the first person to actually pick this up, that this is not AFib. And this could be a horrendous outcome if you mistakenly call something AFib, because you put them on heparin, they can bleed. And we've discussed other cases where patients were inappropriately diagnosed with AFib, inappropriately anticoagulated, and inappropriately developed GI bleeds or other complications, right? Heparin and Coumadin, those are not benign drugs. And this is not an uncommon mistake. So when you see something that looks like AFib, don't call it AFib until you're sure that it's irregularly irregular. If it's regularly irregular, think Mobitz. All right. Think about PACs also. Usually the PACs are fairly obvious, but Mobitz really often gets misdiagnosed as AFib because people don't look carefully. And the final take-home point here, once again, just a reminder, really scrutinize lead V1. Sometimes V1 is the only lead on your 12 lead, which actually tells you what's going on in the atrium. So take a good close look at lead V1. Don't just rely on the rhythm strip, lead 2, that your computer loves to give you. Lead V1 is often the best lead for P waves. So again, my thanks to Joshua Batt for a great pickup and for sending us a case to discuss. Kind of a fun case, I think, and I hope that was helpful. And I look forward to talking to all of you next week. Bye for now.